My name's Sarah Burrows. I'm from the adult service at the Queen Elizabeth Hospital. And you may be wondering why someone from the adult service is talking at a conference for children, but I hope that becomes clearer throughout the presentation. So I'm going to start with a bit of background about myself and my role, and then go on and talk a little bit about LMBBS, and I'll try not to go over too much what Julie and Tanya's already done, and then look at sort of a recurring theme that I've seemed to found during my work. So my role was originally set up from funding through the PCT, and that was through my predecessor. The role was then vacant for several years until I came along and the Birmingham QE took over the funding. My role really is to support and coordinate the renal genetics service at QE, and I do this by liaising closely with the clinical genetics unit. I coordinate the monthly renal genetic clinics, and as well as the paediatric nephrology genetic clinics. I support the Specialist National Multidisciplinary Clinic for LMBBS, and I've also established a nurse-led clinic for the management of patients with a family history of a genetic disease, and that tends to be patients with ADPKD and all ports at the moment. So I just wanted to focus a little bit on the BBS service. One of the key priorities I had when I came into post was to set up a database of the data that we had on our patients coming to clinic. So as we already heard, it was the BBS clinic came about from a successful bid to the National Commissioning Group in 2010. And the objectives for the new clinics included a provision of expert attention and management for our patients. I think we've, in the previous talks today, we've heard about how patients feel isolated, have a lack of confidence in the healthcare system, and by bringing all the specialities together, we're hoping to overcome some of those issues. It developed a model of care that embraces and immediately reacts with the patient experience, and that brings in the partnership working with the charities such as the LMBBS, and I can't really stress how important that is. And from a nursing background, it was quite a new phenomenon for me, and the clinics just wouldn't be the same and run so well without their support. So, like Julie said, the clinic runs roughly about 6 to 8 times a year. Patients attend on an annual review basis, and so far we've seen, since 2010, we've seen 75 patients. The referrals, I'll just jump a bit slightly there, but the referrals come from Scotland, a national really, Scotland, Northern and Southern Ireland. And we've now got patients attending for their 3rd review. Since I've come into post, we've started an outreach service for patients, and that's really where I get involved and go out to see the patient with the aim of actually taking the clinic out to the patient's home. We have a few patients that can't attend clinic for either psychosocial or physical reasons, so I go out and provide as much support as they want or need or I can give. I do bloods, arrange referrals to other agencies, i.e. dietitians. I liaise back with the clinicians, and then we provide telephone consultation through some of the clinicians, and it's meeting the need of some of our patients. So the key priorities of the database was to capture all the demographic details, the genotype, phenotype and the clinical observations, and this meant really hours and hours of trailing through patient notes. We're a paperless trust, so it was actually going through all the previous clinic letters, and obviously we went paperless during the time of when the clinic started, so it was ordering notes, going through notes, getting through some details. In regard to the genotype, out of the 75 referrals, approximately 45 mutations have been found. That's slightly outdated in the last month. 22 patients we've found no mutations. 4 we're still awaiting results. 2 patients have had their DNA stored, and that's for reasons that they're not quite ready yet to know their genetic result. And 2 of our patients have yet to attend clinic, i.e. they've got an appointment, but it just hasn't come round yet. The phenotype, 19% of our patients have a renal phenotype, and that can range from mild kidney impairment to dialysis and transplantation. Ophthalmic, 99% of our patients are partially sighted or registered blind, so that really only one of our patients that has no sight problems at all. Endocrine, 45%. Diabetes, 16%. Learning difficulties, 44%, and out of those 27% were not documented. Neurological is 11%, and sleep apnea 9%. So while I was trawling through the notes, they appear to be a recurrent theme, and that of the psychological aspects of our patients when they were at sort of young age, school age. And this seemed to be a recurring theme of victimisation and bullying at school. And there's a wealth of literature on victimisation and bullying in general, but not when it's related to chronic disease. And Petit et al. In 2010 looked at in particular chronic disease and victimisation, and what they found was that patients with chronic disease were more likely to be victims of bullying, and also the degree of bullying or victimisation. When I was looking at the sort of psychological data out there, they talked about self-efficacy, and the psychologists report it's developed from external experiences and self-perception, so things that have happened throughout our life and how it affects our belief in ourselves, what we believe we're able to achieve in ourselves. That people that are victims of bullying have a low self-efficacy, and that they believe that they can't achieve or attain at a higher level. A further review of the literature demonstrates that adolescents with chronic disease need support in school that foster their sense of self-efficacy and their ability to believe that they can achieve. It then goes on to adolescence, and it talks about it's a time of increase in independence, experimentation, rebellious behaviour. It's a time that's influenced heavily by peer pressure, peer behaviour, and it can often lead to risk-taking behaviour, which then leads to non-adherence to regular medications and treatments, and reducing in engagement with healthcare providers. And historically, there's been a disconnect between paediatric and adult services, which can lead to lack of cohesion and confusion in the management of rare diseases, resulting in a lack of trust between young adults and their family and their adult healthcare team. And that sort of leads on again to transitional care. And again, reviewing the literature, there's a wealth of knowledge that supports transitional care. It supports that it usually occurs between the ages of 16 and 18. And it usually comprises of 4 stages. So there's a need to move to the adult services explained and discussed, with the family and patient. There then goes on to be a combined clinic where the patient and family meet the receiving team for a multidisciplinary handover, a tour of the adult centre, and a final goodbye visit to ensure all aspects of transition have been covered. And I think, as it was mentioned in a previous talk, that's quite variable across the UK, the different centres of how effective the transitional care is. So, should we stop there? Should we stop at transitional care? It's documented in the literature that people with chronic diseases mature later. So, with chronic diseases, their adolescence, is that still in the age of 16 to 24 rather than 16 to 18? And a recent survey shows that the poor level of satisfaction in patients aged between 16 and 24, and there's an underuse of the healthcare services in men aged 20 to 29. And there's very little literature out there detailing the needs of the 18 to 26-year-olds. And it's really on my personal experience in the nurse-led clinic that led me on to this this problem that I was faced with. I see a lot of young people in the clinic, and to engage them is often difficult. It does lead to a lack of attendance to the clinic, and also there's a higher incidence of low mood and depression. People with chronic diseases are 3 times more likely to suffer from depression. And if the young adult is already disconnected with the healthcare system, traditional counselling is not going to be effective because they just won't want to attend for their appointments. And is there a need for a young adult clinic? And that leads me on to the Oxford-London model. This was originally by a nephrologist who worked at the Birmingham Children's Hospital, and he set up a transition clinic there. He then moved on to Oxford, where they had no transition clinic, and again set up a clinic in Oxford. And the idea was to bring together patients aged with the median age of 22, so 16 to 28. It was initially held in an adult outpatient and it was a nephrology consultant, so it was a renal outpatient clinic. And what he found was that there was an increase of delayed transplant rejection and loss of kidney transplant in this age group. So they put together for a grant to set up a young adult clinic, which they got. And like I said, it was initially held in the adult outpatients, and it was partly unsuccessful due to this and hampering of the clinic environment. So the clinic was moved out to a student college and sports centre. It was held every 6 weeks, and with the funding, they appointed a youth worker. So he's seen every 6 weeks with the youth worker, who arranges sporting events, competitions. He looks at their employment. He helps them with job applications. And so really it was to discuss later on this afternoon whether there's a place for this model, not just in nephrology, but throughout chronic diseases, rare diseases. And I think with the government backing at the present time, with the funding with rare diseases, I think it's really important that we make the most of that and get these sort of models more readily available. So I hope it's quite a short presentation, but I hope I've been able to explain why I think adult services are just as important within renal services. And I want to thank Tess for inviting me to come along. I think it's important that even though we might not get involved till the transitional stage, that we're aware of the needs of our patients from a very early age. Thank you.